We thank you so much for joining us today. Our guest, Drew Snyder, Executive Director of the Mississippi Division of Medicaid. Always good to see you there, Drew.
Good to be here, Gerard.
All right, big announcement last week from Governor Reeves about some changes in the Medicaid program, or I guess we could at this point say proposed changes because we await a final approval, right, by CMS. Can you break this down for us, Drew? I think there's two major components of it. What exactly does all this mean?
Yeah, so basically under this plan, hospitals would be reimbursed up to the Medicare rate in the Medicaid fee-for-service delivery system, and then would be reimbursed up to the average commercial rate in the Medicaid managed care system. So Medicare pays more than Medicaid, and commercial pays more than Medicare. There's a recent study that shows that the average commercial rate for inpatient and outpatient hospital services in Mississippi is 193% of Medicare. So there's a pretty big gap there. All told, this proposal is expected to generate up to $690 million in net increases to hospitals annually.
Okay, so let's explain the net, and by that I'll give it a try and then let you correct me on it. But one thing is there's this bucket of money called disproportionate share payments, comes from the federal government, and it is based on sort of the patient care reimbursement payer mix, right, to a hospital. If they have kind of an outsized amount of Medicare, Medicaid, uninsured, the federal government tries to plug that hole because generally that's reimbursed at below cost.
That's right.
Okay, so because we're getting more money under this proposal from Medicaid, would that reduce the disproportionate share?
That's right. It would go down from about $258 million to closer to $30 million.
Okay.
So you really got four pots here that are getting impacted. Well, really a new pool is for this fee-for-service upper payment limit program that would be paying Medicare in the fee-for-service side. An existing program that we call MHAP, Mississippi Hospital Access, Hospital Access Program, that's pays close to between 550 and 600 million right now. That would go up significantly. That would go up, 800 or 900 million dollars, and then the net decreases would be on the dish side, and then there would be a negative impact from a provider tax standpoint because the hospitals will be financing the non-federal share for this. And you probably have a pretty good understanding of how that works, but just for the audience, certain classes of providers, including hospitals, are allowed by federal law to finance the non-federal part of the non-federal share of Medicaid. There's some conditions that are placed on that. So, for instance, it's limited to 6% of net patient revenue, and you can't guarantee that everybody who's paying the tax is going to be a winner.
Okay.
But in reality, most are, and they pay a little. It's not probably like the taxes that you pay, Gerard, but this is a situation where you pay a little bit of tax and you get a lot of benefit in return.
And let's also explain, Drew, that when we say the non-federal share, we're really talking about the state's share.
That's right. Yeah. That's right. So, Medicaid's a joint federal-state program. It's financed primarily by federal dollars in Mississippi. Match rate at that 78% number. It's going to drop to 77 in January. But there are different match rates, but the primary one that's called the FMAP, the Federal Medical Assistance Percentage, is that share that the federal government puts in. So this really these taxes are a way to generate more federal money without putting additional pressure on the state budget, which is always tends to be the harder piece piece to balance
Sure.
and to make sure that we're not running over.
Sits around $1 billion a year, just under $1 billion. Isn't that right, Drew?
That's
the
right.
State's portion.
That's right. We're at 900 and we were at 909 this year. We have been over $1 billion in the past, and our request we've stayed pretty level over the last few years. We are going to be asking for some additional money for state FY25. I know legislative budget hearings are today. We won't be presenting, but there will be some small increases, and some of it's driven. A lot of it's driven by changes in Medicare costs.
Okay.
So, yeah.
Now, will the FMAP 77 be the terminal rate after we unwind the ARPA, right? Well, no, not ARPA. It was the original bill passed under Trump, right, that boosted the FMAP.
That's right. The FFCRA, the Families First, it gave a 6.2 percentage point increase in the FMAP. So we were getting up to 84. But when the omnibus was signed into law in December, they started a step down process.
Right.
So we're, as of October 1, we're going to see the last quarter of an enhanced FMAP. So this weekend it'll go from a 2.5 percentage point bump to a 1.5 percentage point bump, and then it'll be down to normal.
Phasing it out.
That's
so
right.
Commensurate with that, though, you're unwinding the rolls of those who are no longer eligible, which, right, you weren't allowed to do. There was a kind of a moratorium on disenrollments under that law passed in 2020.
That's right. So basically, we froze. We couldn't cut off coverage for anyone who was potentially ineligible for that 3-year period unless they died or moved out of state. So consequently, we saw enrollment go up by about 26%. So I think at the end of March of 2020, we were at 716,000, and by June 30th, the last month before we started those disenrollments, we were up to 904,000.
Unbelievable.
We're still about 140, over 140,000 above where we were prior to the pandemic.
All right. So with respect to the governor's announcement, Drew, there wasn't anything new announced by the federal government, no changes in regs, or it was something like just popped up, said, okay, this is available now, let's go leverage this?
Yeah,
explain the background.
The rules have not, there aren't new rules that have triggered a change, but supplemental payments have become more popular, and there's kind of a growing body of work. If what you see that CMS will permit, and other states have really, and it seems to, this idea of average commercial rate and managed care seems to be where things are starting to kind of land as the ceiling for Medicaid reimbursements in managed care. So it really is just for us, it's been learning more and getting connected to financial experts that have seen this in other states,
right,
and seen what CMS uses and will accept as these estimates, these reasonable estimates of an average commercial rate.
Okay. And we have for the benefit of the audience, we have two delivery models, right? We have the MCO model, the fee-for-service model. And in the MCO model, we're essentially just paying a third party some set amount per enrollee covered. Is that right?
That's right.
We just send them a block of money per person. But under this program, though, Drew, these are direct payments over and above that to the providers. Is that right?
The managed care plans essentially act as a conduit to make these payments to the providers. Now, it's a little bit more complicated than that, just like anything
Always.
in Medicaid is. And part of it, and one of the reasons, one of the appealing features, I think, of this program is that it's tied to quality. And the managed care rules, one of the things that they have to do is that it's expected to advance a quality strategy. And I think this is probably the most immediately impactful intervention that we can do to help hospitals. But it's more than that. It's an effort to not just help our members, but drive care quality down the road and really build on some of the things that we've done over the last few years with hospitals on reducing readmissions and potential complications.
So as I understand it, Drew, the federal rules simply say, and this is what's a little confusing, I think, for the average person. It's not like the federal government says, here's a pot of money to go run Medicaid. Each state can structure that program within constraints to some extent the way they want. But, and we'll talk about this on the other side of the break, but what I can tell is they expect actuarial soundness, right? That's the terminology they use, which could be interpreted a lot of different ways depending on the actuarial analysis.
That's right. With actuarial soundness, there's a floor, but there's really no ceiling.
Okay, gotcha. Well, can you stay around? Got a few more questions. We got Drew Snyder, the Executive Director of the Mississippi Division of Medicaid, in the Element Well studio. We're pleased to have Drew Snyder, Executive Director of the Mississippi Division of Medicaid, in the Element Well studio. So, Drew, you and I were talking offline. This is just complicated. Healthcare in general. And I think it's because it's one of the only industries, maybe the only, where there's no standard price to the consumer, right? There's at least four. You got private coverage, Medicaid, Medicare, could have TRICARE, and then you've got out-of-pocket. You could just, pay out-of-pocket without coverage. All of that figures in, and all these providers constantly track what they call their payer mix, right? Mm-hmm. Who's paying them?
That's right.
Because it's different, as you indicated. And something else that even though the governor announced, and you just said it as well, that we're approaching commercial reimbursement rates, those are actually quite low in the state of Mississippi relative to other states, even our neighboring states of Louisiana and Alabama. And that's figuring into the financial health of hospitals as well.
Yeah, and that's the commercial rates are that's. It's something to keep an eye on because, on one hand, we want providers to get adequately reimbursed. We also don't want our premiums going up.
Right.
And I think one of the other hard things about healthcare is there's not a lot of willingness for trade-offs. So, some of the hard decisions that can come up there, there end up being winners and not winners, and it's sometimes hard to pull the trigger when there are these entrenched interests, and maybe most importantly the consumer.
Yeah. So, and let's be clear to the audience here as well that this move is not so-called Medicaid expansion, which is a term that I think almost everybody's familiar with, which would really just entail adding a coverage group to the current Medicaid program, that coverage group being able-bodied adults. When the program was created back in the 60s, originally it was designed for the coverage groups that traditional Medicaid covers. Go through that for
That's
us.
right. The original design of the Medicaid program was for seniors in need, individuals with disabilities, low-income, pregnant women, so that's with family incomes up to 199%, and low-income children and certain caregivers. So the proposal that was announced last Thursday is focused on reimbursement increases for the 860,000 of really the most vulnerable population in the state that Medicaid covers.
Yeah, and about half of those are children. Is that
That's
still
right.
about right?
That's right.
Who consume less services. I mean, they're healthier folks.
That's right.
And you've got a lot of children that qualify in households where the parents do not.
That's right. So our cutoff for what we call the low-income parent caretaker population is in that between 20 and 30% of federal poverty. It actually changed. It actually is a fixed amount. So a family of four, $587 dollars a month. But when you get into for instance, pregnant women, new pregnant mom, that goes up to family of two with mom and a newborn, $3,200 a month.
Okay. So something I'm curious about, Drew, is all the states don't have the same income eligibility model. How much latitude does the state have in determining that? In our case, right, the different coverage groups, we even have different income eligibility numbers.
Yeah, My understanding is some of this was grandfathered in, so you can't go down. Now you could go up. There, some states that have lower thresholds for low income caretakers that we do, and then there's some. Now our 199% number is probably in the ballpark. There's some other ones that are higher, and that's the same. Same goes for the CHIP program, where it's up to 209% for those children from families with a little with higher incomes.
Yeah. So I have a report from the General Accounting Office, this federal GAO, that discusses improper payments from the federal government. $270 billion of improper payments from the federal largesse last year. The biggest category, sadly, is Medicaid. Nationwide, $80 billion. And, Drew, I've always wondered, is this because we have folks who are receiving Medicaid benefits that aren't qualified? Do we have providers maybe that are sort of, abusing the system as well? Combination of the two? Where's that $80 billion coming from? What's the root cause there?
It can be for something as innocuous as documentation, and that can drive a number up. But it could be eligibility errors, or there are for children in Mississippi get continuous coverage for 12 months, but there are some reporting requirements for others when they go over those income limits. And there is there's certainly abuse and worse, across the Medicaid program nationwide. Certainly more than I would not go to say prevalent or widespread, but certainly more than what we would like, which would be zero.
How does the Division of Medicaid in the state of Mississippi, Drew? How do you go about determining eligibility based on income? What's that process look like? I think a lot of folks in Mississippi are concerned that, hey, I know people, I've heard this anecdotally, I know people who qualify for Medicaid benefits that really shouldn't be qualified.
So we run, the applications will come in, and there are different pieces of information that are provided with that initial application, and then we'll run it through various databases to see if there's alignment, and if there is, we can make a affirmative eligibility determination. And at least once every 12 months we are, while suspended during COVID, but we do the renewal of eligibility. And that starts with we will start with looking at those different data sources. Again, there's a feed from the Department of Employment Security, and a number of different data sources where we can try to confirm that income. And if we can't determine that they're eligible from that information, or determine that they continue to be eligible, we send this pre-populated renewal form to them where they can return to us and update information as needed.
So I've seen some reports with the disenrollment that's happening across the country that a lot of people believe that a lot of beneficiaries believe they are actually eligible, but there's just documentation requirements, right? That just fall short of.
Yeah, you've probably heard a lot about that. There's been a lot, in certain segments of the media and from certain, advocacy organizations about procedural disenrollments. And now that could be people that don't know that know they're not eligible. If you have a 22-year-old that was kept coverage in a child category for 3 years because of the continuous enrollment condition, it may not be turning their form back in, and no, they're not eligible. Or there are other cases like that. But there are also situations where somebody that they may not get to it, or do they not have the and so we do have good. They can return. They've got 120 days to return that information after and have their coverage reinstated to the point that they lost coverage. So there are some opportunities if people don't turn that paperwork in right away, that they can get back on without having to submit that application. but from an administrative standpoint, we would much rather, the information get returned, and so we can go ahead and make those decisions.
I got you. All right. So if someone's enrolled and they qualified based on their income, but then their income rises such that they would no longer be qualified, how does that work? How do you guys check that?
Well, with children, it's part of the 12-month renewal cycle.
Okay.
Yeah.
Okay. So there's a 12-month renewal cycle.
That's right.
Okay.
That's
so
right.
It's not like once you're in, it's permanent, and we rely on you to tell us if your income changed or something that would disenroll you or disqualify you.
That's right. So the caregiver group, that would also apply to pregnant women. There's 12 months of continuous coverage there, and then another category like what we call that low-income parent caretaker group. They've got some reporting responsibilities, but if they go over income, they can qualify for something called transitional medical assistance, and they can stay on for a little longer.
In that group, is that like 45% of the federal poverty level or something around that number? It's pretty low, right?
It's pretty low. It's been in the 20s, and because it's a flat number, it goes down. It goes down every year.
I got you. And that's what causes the so-called donut hole between that group and those who would be eligible for coverage in the Obamacare marketplaces, the ACA marketplaces,
That's
which require
for
100% and up.
For the caregivers, and then for non-caregivers, there's not a
Nothing.
Medicaid.
Right.
That's right.
Gotcha. Drew, always appreciate you, sir. Thanks for coming in and explaining all this. Take care. I'm sure we'll be talking soon. Appreciate
Thanks,
it.
Gerard.
Yeah. We're coming right back in the Element Well.